All right, it looks like we can get started here. So we have a special guest with us today, one of my former colleagues who's now out in San Diego, where my son, I think, sometimes wishes we were, as it's been 0 degrees here. So Mike Kelly's here. He's going to talk about AIS and targets for alignment, I believe. I typically don't treat children unless they have a tumor, and so I typically don't treat AIS. So those of you that do, please feel free to put in comments in the chat bar here, and obviously the co-panel members obviously speak up with any questions and interrupt, and we'll try to get to them. The only thing I'll say about Mike, I think I've said it before, he was my partner when I started here at WashU, and he was everything you could ask for in a partner in terms of being there to help and always willing to go over any case really at any time. And also one of my favorite cases was when I got into a renal cell tumor, had a lot of bleeding, and said, "Is Mike around?" And he jumped in the case within probably 60 seconds. And not only did we control the bleeding, but he was, within a few seconds of being scrubbed in, was making small talk and everything was cool. So always happy to hear him talk about alignment, because not only does he probably know more than anyone, but is also very passionate about it, and probably has thought about it more than all of us combined. So Mike, with that, I'll let you take it away.
Thanks. For all the attendees and panel members, I was telling Matt, I did this with this case, and I put together the talk just to sort of cover things I've talked about in the past with some new stuff, but I'd like to keep it very interactive. So as you have comments and questions, particularly as we talk about planning for a case, please speak up. And yeah, as Matt said, I was in St. Louis for a decade. I had a pretty sweet practice. I did lots of cool adult deformity. I did lots of cool pediatric deformity. I have lots of obligations to things like the ISSG and the harm study group and the AO and the SRS, and I was getting drawn and quartered a little bit. And while the heterogeneity of cases is fun, it was a little bit distracting in terms of me focusing my research and interests. And my two real main interests are spinal alignment, which I think we are getting much better. But for a long time, we didn't really even give thought to what the segmental alignment for a 4-5 degen spondy fusion was. Whereas for all the orthopedic surgeons on the call right now, you know what position to fuse an elbow, you know what position to fuse a shoulder, but we don't really know what position to fuse the spine. And my other interest is in understanding the sterile response to trauma, or the response to trauma, where sterile response is a nice model and spinal deformity surgery is an outstanding model of trauma. So that's coming here was an opportunity for me to take a nice, very clean subset of spinal deformity patients, being AIS, and to understand both alignment and how we can, are there any unifying factors in terms of alignment? And you will see in the call that, a lot has been done, but I think we're really on the cusp of making real progress and no longer tilting at windmills here. So disclosures, I'm an editor at Spine, and was on the SRS board of directors. I'm in the AO Knowledge Forum. It's for people submitting abstracts to the SRS, they know that right now it's crunch time. And this is an email that I received this week in 2024, talking about one of the sagittal alignment studies we're putting in. So this is a study that will get some love from reviewers because it reinforces what we do clinically. We try to get as much as we can and see what happens. That's terrible. That's terrible. And what I brought it when I was proposing Matt's laughing, when I was discussing these studies at our general research meeting, I said, we in the harm study group, there's definitely malalignment, and these kids forgive all our sins. And the adults don't forgive any sins. The adults fail quickly. And I mean, realistically, and like Mike Selby, I see some of the revisions you have to do when you post stuff on social media, and I know what Matt does. if total hips failed at the rate that spine surgery fails, that it would be Wall Street Journal front page news, and they'd be illegal. But we get a pass with spine surgery. And I think we really, really need to do a better job of making these surgeries durable. And as an example, right, get as much as you can. Here's a case where they use the bands, right? In theory, the bands help improve your thoracic alignment. Initially, looks kind of okay. Those looks like they're trying to hold on up top, but then at 6-month follow-up, that patient has already failed with PJK. And this is a child, right? Imagine if this was a T2 to the pelvis, this would be a disaster in a 65-year-old. And some of you may have heard me go on and on about this in the past, but those red lines, I'll go back, the red lines are the L1 pelvic angles. The L1 pelvic angle is a number that describes the shape and magnitude of lumbar curvature. And it accounts for more variance in terms of alignment than does just describing lumbar lordosis. The T4 pelvic angle in adults has a nice harmony. And you can see here, this AIS kid, look at that. T4 pelvic angle and L1 pelvic angle are in perfect harmony before surgery. But then when we flatten the thoracic spine, look at T4 is now dorsal. When T4 is dorsal, the head tries to go ventral, and then you're off to the races. This is something we know a little bit about, and it has been written. PJK is a rebalancing phenomena due to insufficient thoracic kyphosis, written by the French groups. For those of you that aren't French, I would encourage you to look up a lot of what Dubosset has written, Roussely has written, Lehuic has written, and now Philippe Charles and Sebastian Pezzenti, I think, are doing really great work. And I say, look at this case, right? Immediately post-op, really flat, and they're trying to rebalance. Dubosset says balance is dynamic, and sometimes people get a little offended when we say balance for a static radiograph. I tend to agree with Dr. Lehuic, Dr. Lehuic calls it the odontoid hip axis. Hills and I call it the C2 tilt, which is, I think, like more accurate for in terms of everything else that we've done. People try to stand with a C2 tilt of 0. And you can see on that immediate post-op x-ray on the left that that patient is extending their neck like a giraffe to get that head back over the sacrum. Or sorry, over their hips, not the sacrum, over their hips. And the same thing happens to that patient after their flat back. And the problem is that if you are failing and you retrovert, your hips are getting further away and your head needs to extend even more to get out there. And
So here, before,
Yep.
not to simplify it too much, and I'll shut up as the real AIS people take over. But so is the mistake in both of these the lack of thoracic kyphosis?
Yes. Yes. And I have some slides later, but the problem is that it's a 3-dimensional deformity. And Matt's heard me sort of go on and on about categorization. In reality, like the fact that we're making a 3-point plane system for it is a little bit categories. We're calling it X, Y, and Z, as opposed to it is this 3-dimensional deformity that is balanced. And there is a great desire for low Cobb measurements after surgery and derotation. And as you try to do those in very general terms, you tend to lose kyphosis. And that brings me back to Matt. I don't know, have the SRS traveling fellows come through WashU with you there? Not yet. We got to get them back on the schedule. Because they're always the SRS traveling, and anyone that's on the call that's a junior member, make sure you apply to this, because I think it's a great experience for both international people to come to the States and people in the States to go internationally. They come with a chaperone. And Mr. McMaster, the congenital scoliosis master of the universe, came and was watching us at St. Louis Children's, and we were doing very extravagant derotation things with towers, and stuff was linked together, and it looked real cool, and fellows thought it was awesome, and I thought it was awesome. And at the scrub sink, he said, Mike, the more stuff you try to do to those 2 planes, the more you flatten the spine, and that's not going to be good in the long run. And I didn't realize, we're doing this and we're pulling up. But if you think about the math of it, it's really true. And that's where it's a balance of figuring out what's going to be a good longevity with giving the patient or the child in these cases a cosmetic result that they are satisfied with. So, and here's oh, we have chats. Are people asking questions? No. All right. Thanks. Yeah, Matt's going to keep an eye too. So we'll start with the case, right? This is a 15-year-old postspinal young woman by proximal femurs. She is on the tail end of her growth spurt. She went from 45 to 70 in a really, a fairly short amount of time, just over 12 months or so. And these are her preoperative radiographs, right? Pretty standard right thoracic main curve, small proximal thoracic curve, small fractional, and that's where this is where having the adult and pediatric experience is understanding that this thing below here is a fractional curve, right? It's only half of a curve that stops at the sacrum, which when you start thinking about the way Peter does things with AR and AL curves actually matters, understanding that fractional curve. And here's her sagittal. C2 tilt is perfect. Shape of her spine's a little funny. It's a lot of kyphosis up high. Then it's reasonably straight in the shadows. This is what, I love Peter Newton, my partner. I've learned a ton from him. We agree probably on, just like with Virginie Lafarge and I and other people disagree. We agree on like 99% of things. He calls this the Kelly shadow. He's like, that's not what the sagittal plane is, Mike. And I say, well, it sure looks like it's all we're looking at. But it's a difference of opinion. So I would say that the shape of this is a little funny, right? There's high thoracic kyphosis, then it's reasonably straight, almost homogeneous through, I would say probably T5 to L2, and then a small curve at the bottom. She has 4 lumbar vertebrae, which for a while for me because I'm a nerd and I like my PI measures and things like that. When they have a sacralized L5, I didn't really know what to do. I spoke to Pierre Rousseli and he was like, just measure it off of S1. Don't even like concern yourself. Just count 12 thoracic vertebra, then count down and go off the 6th lumbar or the actual sacral segment. So this is L5. Matt, can you guys see my pointer?
Yes.
All right. This is L5, so her sacrum's down here. Pretty standard for me. I like to get supine radiographs to get some idea of what the flexibility is just in the absence of gravity pulling on it. And one thing I think is important to note here, at least again, there's differences of style and differences of opinion. This would not, you'll see on the benders, this is an appropriate thoracic fusion. But when you're thinking about doing selective thoracic fusions, Keith Bridwell's experience, my experience, and Larry Lenke's experience was that the lumbar curve correction, and note it's not spontaneous correction. There's nothing spontaneous about it after you have surgery. The lumbar curve correction tends to mirror what the spine looks like supine. The unfused segments tend to go there, and that helps you guide how much straightening you can do of the thoracic spine. If you look at her supine lateral, you can see, look, I would say there's a little bit more mid-thoracic kyphosis, in part probably because this curve has come down a little bit, and a little bit, I'd say, nicer harmony through the lumbar arcs of lordosis here. And we get our standard benders in part just to make sure that we have some sort of classification to help guide our treatment. That's one of the real benefits of the Lenke classification. In research, it gets a little bit, I don't know, abused as if they are different diseases. It's all AIS, and the Lenke classification was just created to help us choose the correct fusion levels, right? So on the left bender, that fractional lumbar curve essentially goes away. It's under 10. PT curve is there, but it's not for me. I don't even know the little lingo that our fellows always come in with, the T2, shoulder up, this, that. I don't look at it that way. I look at the proximal thoracic curve, how stiff it may be, how much I'm going to correct that main thoracic curve, and how much I need to really control the proximal thoracic curve to control that right shoulder. So I would say here from T1 to T3, there's really not any curve. So I can safely stop at T3, provided the sagittal plane cooperates. And then it's a somewhat stiff curve. This is not a great way. Doesn't look like she's really bending at all through her thoracic spine here. A prone bending film might have been bender, or 3-point, a push prone, sorry. So it's a lanky 1AN. And now let's get into the weeds a little bit, right? So now, for a long time, and I would actually say like Themi-Protopsaltis with multiple things has been light years ahead of me. And I remember doing a meeting with him, I don't know, 7, 8 years ago, and he asked me what planning software I used, and I said, I just measure the x-rays and make a plan. And he was like, that dude, that's antiquated. What's wrong with you? And now I'm infatuated with it. So I would say whatever your planning software you like, this is the one I like. And you get the femoral heads, right, sacrum, and we determine all the vertebrae. And the green, and this is, I think this is important, this concept. Green is the lordotic arc. Yellow is the kyphotic arc. And this is a little bit where the L1PA concept comes into play versus just LL, and certainly against PI-LL mismatch. And it's what Roussely talks about, that Roussely notes very importantly that your functional arcs of lordosis and kyphosis are not necessarily L1 to S1 and T1 to T12. They vary with your pelvic incidence. And once you understand that, I think it helps you understand better distribution and shapes. So this patient, right, and her PI measured off of this down here is 75. That's a very high PI patient. And in the Roussely world, that means it's going to be a type 3 or a type 4, more likely a type 4, because that's very high PI. And all that means is a large S-shaped spine with a arc of lordosis that extends into the lower thoracic spine. A type 1 at the other end, for example, PI of 40, is going to be a long arc of kyphosis, T2 to L2 or L3 maybe. And then that lower, the L3 to S1 is where all of their lordosis is going to live. And that's how you result a type 1 shape. Frank Schwab doesn't like this classification a whole lot because he says it's not, and it's true, right? Categories are not great. And if you understand and accept that it's a spectrum, and it's really, there's a 1.1 and a 1.2 and a 2.5, and it's just a spectrum based upon, for now, your pelvic incidence. And Roussely actually uses sacral slope, but I still can't wrap my head around using a non-fixed parameter. Where sacral slope and pelvic tilt are not fixed, right? But his plans essentially are to aim for a particular sacral slope, which I still think is kind of challenging, which is why I like to plan for an L1 pelvic angle. So in this patient, we can see this is T11. So her lordosis arc is T11 to S1. The program picks it up for us, and it's 81. That's quite a bit. That's a lot of lordosis. Though not too bad for a pelvic incidence of 75, it's actually 60% plus 30, pretty close. And then the kyphotic arc is T2 to T10. She is well balanced, right? C2 tilt is 0, well balanced. And I would say well balanced, but probably slightly malaligned despite all of the greens that are here. And why would I say that? Because I don't love her neck. I don't love the fact that the neck goes over like this. And while the notion of cervical lordosis, I think, needs to go away, because there's plenty of papers that show the wide diversity that exists for cervical curvatures. I would really prefer to be able to get an alignment where she can have some cervical lordosis and perhaps not load those discs so much, because I don't know what the long-term effects of a T3 to L1 are with cervical, either neutral or kyphosis post-op. We look at the coronal. This is where we're going to help pick our levels. This has got a small riblet on it, though this one's T12. Large rib on T11. End vertebra is T3, or no, one. Let's see, that's 1, 2, 3, 4, 5 to 11 is the major cob. Last touched is L1. Last substantially touched is L2. Because it's so flexible on that bender, I'm not worried about stopping at L1. I do think that you need to be careful with the 1As that when they bend, they do have some, right? And you got to remember, like everything we've done, there's limitations to it. With the Lenke classification, the choice of structural, non-structural was expert opinion in the room. And it may be that that's not what it means. And if you bend out and you have like 15 degrees, but it bends out, you have to be careful about going to this last nicked, because that's could be these fractional curves tend to be 1AR type curves, and it's usually better in the long run to go to the last substantially touched, to L2 here. But this one bends out, so we can go T3 to L1, and as long as we're happy too on the lateral, you got to make sure on the lateral that that's okay. So we're planning a T3 to L1. T3 to L1, fine. We can put the screws in and use however you like to fix it. Doesn't matter. You can fix it, right? The real question is, and what I've told Peter recently is, I am like, now that I'm obsessed with trying to do this perfectly, right? As part of the reason to switch jobs was to try and figure out how to do something perfectly. I don't know how to bend the rod anymore. I don't know exactly where I want things to be, and that's what we're working towards now. I think understanding the development of the spine, and particularly, I put this middle spine in the talk again later. I think this is very important, understanding how the spine develops. And now this is a study by Pezzenti and Philippe Charles, where they looked at just normal children in developing. The limitation, right, is not that it was one kid followed over time. It's groups of children, but it's 1,000 kids. And more likely than not, the averages that they find are probably pretty close to what is true, even if you tracked an individual over time. But one of the things, and we're working to do this with pelvic angles with these guys, because I think that measuring TK and LL, I think that there's a real limitation to that, as I noted before from the work of Rousseli. But they measured all of these things. They measured they measured thoracic kyphosis, lumbar lordosis. They measured the arcs of kyphosis with proximal, main, distal arc of kyphosis, and then the proximal arc of lordosis and the distal arc of lordosis. And PI-LL. Or sorry, PI, sacral slope, and PT. And what do we find? In general, you know, your pelvic incidence definitely changes at a very young age. So as you're a baby to 8 years of age and your pelvis is growing in an A to P, it really depends like what vector your hip socket goes at as it grows away from your sacrum. So your PI does change through very early childhood. And I think that's why like fixing some of these juvenile idiopathics or juvenile, any like early onsets, really challenging, because their spine's growing and you're fixing particular spinal measures in a time when everything else around it's growing. The change is really small, but PI does change, and essentially you're left with a PI of around 45 in their numbers, 50 in some other groups. Work 45, 50, I think, is a reasonable thing to think about in terms of where PI or where your pelvic incidence goes. If your pelvic incidence is changing and you are and learning, that's the other thing too, is at a young age, like for those of you that do pediatrics, you know, like you get x-rays on kids and sometimes you're like, you got to redo it. This is totally useless. They're standing crazy, not useful. But in general, as you get mature, you move dorsal. You learn to stand upright. And that's why like that middling postural kyphosis on the slouchy teenager, I always tell parents, don't worry about it. They're just being a teenager. Pick your battles. Don't argue with them about standing upright because they're going to do it later. Don't worry about this. It's going to move back with time. As their PI changes, the pelvic tilt changes. Sacral slope seems to be reasonably fixed in this cohort. And if you think that should make sense, that if your PI is changing and your sacral slope is not changing, the only thing that can change is your pelvic tilt. And back to what I said about A to P growth of the pelvis and whatever vector your hip joint's going at, you just think about that As that moves away, your pelvic tilt's getting higher and higher and higher. And that's what this shows, right? Pelvic incidence, slight increase. Pelvic tilt increases with your increase in PI, but your sacral slope doesn't change. And now that's the foundation, right? This is the base, right? The PI is the pedestal that drives your sagittal curvatures. And now this is what, like this first part, this is what I have a little bit of beef with. I don't love the notion of just calling it L1 to S1. I find that very not useful. The last graph here is really key. I don't know how many of you got tortured by the time Matt asked me to do this last time, and I went for like 80 minutes about sagittal plane in adults. But it seems that it's very consistent that adults have L4 to S1, 35 to 40 degrees of lordosis on average. And I know that a lot of us will say, well, no, 60% of your lordosis needs to be low. I think that that's actually a mathematical, it's just mathematical trick or luck. Because if you say 40, and then you say, okay, well, the average PI is 50, well, a 50-degree PI should have a LL of around 60. What's 2/3 of 60? It's 40. It's just the fact that the averages are working out. And we erroneously conclude that it should be 2/3 of your distribution, when in fact, it really seems very fixed. So sacral slope is fixed at a young age, and that L4 to S1 lordosis is reasonably fixed at a young age. But your PI is changing. So now, if your PI is changing and your low arc of lordosis is fixed, what is changing? Your upper arc of lordosis is changing. And I think that's important to understand, because that's where we can affect some change to achieve a personalized or precision alignment. And then, and you can see it here, right? Look at, as their PI is changing, the upper arc of lordosis is changing to help them maintain sagittal balance. If the upper arc of lordosis is changing, I'll scroll back. What else is going up one for one with it? The lower arc of thoracic kyphosis. It's geometry. Right? Lower arc of thoracic kyphosis is equal to the upper arc of lumbar lordosis. The lower arc of lumbar lordosis is equal to your sacral slope, necessarily. Right, so as they mature and that PI goes up a little bit, there's a small increase in lumbar lordosis, and it's occurring all in the upper arc, which I find very fascinating, because that helps us understand how the rest of the spine is developing, and also gives us some idea of how to change things. So now, looking at the thoracic kyphosis, this is the other thing too, that people that try to define thoracic kyphosis based upon PI, it's missing a really critical element, and it's that the thoracic kyphosis exists in response to the PI and the lumbar lordosis distribution and magnitude, because the ultimate goal is a C2 tilt of 0. So when you just use PI to come up with a mathematical equation for something for their thoracic kyphosis, I think that's a windmill. I think we're chasing a windmill there. So what do we see here? The proximal thoracic kyphosis tends not to change in normal children, no spinal deformity, and it is small. You can't see here, but it's about 10 degrees, and it's about 10 degrees off across all of their age groups. And if you think back to the case that we showed earlier, her upper thoracic kyphosis was about 25. So she's got proximal thoracic hyperkyphosis at the inflection point between the proximal thoracic and main thoracic coronal deformities. And the inflection points where curves change, they're always relatively kyphotic. So she's got proximal thoracic hyperkyphosis. And we're trying to think, now looking, right, main thoracic, I'm not so worried about that. And then the distal thoracic kyphosis also changes with time as their PI is changing to maintain sagittal balance. So there's a small increase in TK. The mean across the ages, I think this is really important to note also, it's about 40 degrees. And if you look at our papers in the harm study group, for the most part, thoracic kyphosis post-op is under 30 degrees. And perhaps that's okay, but the reason I'm really fascinated by this is that I think it's probably not, and we are confusing these really resilient, healthy kids with good surgery, right? And we can do better surgery. And this increase in thoracic kyphosis occurs through the lower arc of TK. So let's look back at our patient, right? What do we have? We have thoracic kyphosis that's exaggerated in the upper thoracic spine. And we have probably too little distal kyphosis, right? The shape of this arc is not wonderful. There's too much, the length of the upper arc of lordosis is probably a smidge too long. And we need to trade some of this kyphosis up here for kyphosis here. How are we going to do that? And why does this really matter? It's because when you do these surgeries, and this is what I was getting at a little earlier, Matt, this is a, I think, really famous and important picture that Peter Newton has in his JBJS paper talking about true or 3D true kyphosis, where he removes the coronal and axial plane deformity, and you get that spine that's on the right. So this is the same person, but that reconstruction on the right is where you have done a perfect coronal plane correction and a perfect axial plane correction. And now look at that spine. It is relatively long in the front, and it's the so-called lordotic spine. And as we think about correcting this and adding kyphosis in places, we need to think about, are we going to shorten the spine? We here, especially with Peter, still have a pretty strong anterior thoracic practice. Doing it with the thoracoscope it's really sweet. If any of you come to San Diego and want to see Peter do it, he's a wizard. It's really nice. They get a chest tube, but other than that, like, you sew the pleura back up in the front of the spine, and it doesn't really change their discharge disposition or time to discharge. But you take the discs out, and everyone in the harms, we call it anterior release. I really want it to be thought of as an anterior column shortening procedure, because we can do facetectomies. You can take the flavum out in the back if you want. But I think Chalar Yilgor thinks so too, that at some point the PLL becomes really the check grain to how much you can do. And you can't do that much posterior lengthening without stretching the cord too much. And you really need to think about how you're going to shorten the front if these patients really need a lot of kyphosis, or it will be the balance of coronal, axial, and sagittal plane correction, which is what Dubuisset has always argued for. You can say something, Matt? I saw you unmuted.
No, I was just going to say, the correct me if I'm wrong here. I was going to say, as you were showing all those data, that these changes in these parameters seem relatively small. And I think what you're saying is that as they age, as they mature, and I think what you're saying is yes, but when we intervene at the same time, we're making changes going the other direction, like like flattening out the thoracic kyphosis. Am I getting? I mean, and the distribution matters, but I mean,
yeah. I think for me, it's just understanding where all of these changes happen as we develop that will help you understand where to put the changes when you're trying to restore normal.
Yeah.
Because there's a lot of PEDS X-rays where they just measure TK, right? And we don't, just like I harped on with the adult stuff and the lumbar lordosis magnitude and distribution. In the PEDS world, they just measure TK. They say, okay, it's 28. It was 12. Bang up job, everybody. But it looks like this, right? It's all proximal, and then it's straight. And that's a terrible shape. And I don't know if you have revised any of those, but when they degenerate, it stinks, because if you have a flat thoracic spine, your T4 tends to be more dorsal. So if it's an adult who now needs lumbar reconstruction for degenerative discs, however many years later, if you try to give them a normal lumbar alignment to give them a comfortable pelvic tilt, T4's PJK City. And if you want to leave them back in a C2 tilt area of 0, you can't give them that much lordosis to restore a normal pelvic tilt. And that, as we all know, or as I believe at least, that's associated with disability. High PT is not good. It's uncomfortable to stand and walk like that. Does that make sense?
Yeah. Oh, yeah.
And so now we're thinking about how we're going to balance this correction, right? Back to the planning software, we can correct the coronal plane while we look at the sagittal plane. So this is this software is nice. It does an immediate 3D reconstruction for you. So this on the left is no correction. This is that spine that we're going to fix in 3D. This is it with a 30% correction of that coronal curve. So 70 to 50. This is it with a 60% correction. And this is it with a 90% correction. And we can see now what flattening that spine has done. Look at this part is flat. And historically, we think that that's good. I tend to not think that's good, because now if you take this spine, which is how she stands now, and you overlay this, it's going to pull her back. It's going to pull her back a bit, and then she's going to want to put her head forward, and it's a child, and she'll probably do fine. Right? We're going to see how much we can get and see what happens. I think that's not wonderful. So now this is, I'll show some new stuff too. So that Dubosset, if you haven't listened to any of his talks, you should. Absolutely brilliant. Has really talked about how AIS achieves harmony in the setting of this deformity. And I put up the other image from our adult normative alignment paper, because you can see that independent of PI, people stand with a C2 tilt of approximately 0. Excuse me, -3 to 1 for the most part, independent of pelvic incidence. The lordosis and kyphotic curvatures and distributions all vary with your pelvic incidence, but they all do that to achieve a C2 tilt of 0. And when you listen to his lectures, he says, be careful, trying to do too much of this, trying to do too much coronal plane correction, you can lose the harmony. And Matt, you may have heard Keith Bridwell say that in conference, but Keith was really adamant in the OR when we did AIS with him. Don't monkey with it too much. Don't try and change this too much. If you try and change it too much, you're going to take this harmony that they have achieved and you're going to lose it. And you may not have to fix it now, but if you follow that patient for 20 years, you may have to fix it. And that's the thing too. In peds, a lot of people do peds only. So you fix it at 15, at 21, they're gone, and you have no idea what happens. And I have a couple young adults in the practice here that have devastating spine alignment with degeneration in their early 20s. And one's a boy. He's a young man. He's got to get fixed to his pelvis whenever he wants it for these vacuum discs in his lumbar spine. And think about that. First of all, if you want to do it right, I think you can go in the front. Retrograde ejaculation, that's like, be patient. You don't want to mess around with an anterior on unless you have to. And then if he gets fixed to his sacrum and pelvis at a young age, we're changing what jobs he can get. If he has children, he's not going to go out and play normal with them. He's never, first of all, like once you get to be I'm Matt, I don't know about you. I don't run normal anymore. That's how you know when you're like old, when you like go to run with your kids and you run like a spaz. I have reached that level. But this guy will never run normal. He'll never play normal catch with his kids. All because I think we gave him a non-durable solution and did not achieve harmony. So this slide, I find this super fascinating. I haven't presented it anywhere yet. I submitted it to the SRS. We'll see. Sometimes people don't find what I find interesting. I would challenge you guys on this call. One of these is AIS. One of these is a normal standing adult. Which is it? Does it really matter? Probably not. This is the L1 pelvic angle, right? That is the angle subtended from S1 to the femoral heads, the centroid of L1 to the femoral heads, which we've described in the past as a measure of lordosis distribution and magnitude. The scatter plot on the right is the normal standing adults. I'd argue that an R squared, and we'll round up to 0.6, an R squared of 0.6 in a biological system is pretty remarkable. That's pretty darn good. That means we are accounting for a lot of the variance in this one measure, the L1PA, by their pelvic incidence. And if you want to use that in the error bars, there are 4 degrees. So 4 degrees on either side, which is kind of nice, because to say that you're going to nail it perfectly on the button every single time, I think that's a little aggressive. The L1PA in a normal standing adult was 50% of PI, right? 0.5 times PI minus 21 degrees. For the SRS cycle this year, and again, part of my goal here in Rady Children's, I measured 330 preoperative adolescent idiopathic scoliosis kids that were at the end of either skeletally mature or at the end. They're essentially all RISR 4s and 5s. So they were out of that developing spinal curvature phase. And look at that, R squared 0.6, 0.49 of PI minus 19. And while it's not identical, I'm going to say that's the same as a normal standing adult. In the setting of coronal and axial plane deformity, the spine finds harmony. When we presented this at Harms, Sukin was like, it kind of proves everything that Dubois has said. And we're submitting all, like, Rousseli, right? We're trying to convince those guys that the T4 and L1 objectifies that classification system that actually, unless you spend a lot of time with it, has pretty poor inter-rater reliability. Some people are just like, this doesn't make any sense. If you use the L1 PAs and T4 PAs and then you classify them according to Rousseli, it's like on the button. It's incredible. So we have objectified Rousseli, and now we have objective data that says, for the most part, Dubois on the button. I didn't put it in here, is that the range of C2 tilts is actually a little bit broader than adults, though most children still align with a C2 tilt of 0 in the setting of adolescent idiopathic scoliosis. As I move forward with this, and anyone on the call that does research, I think one of the interesting things will be, can we, and I hate classification, but will we find that some AIS is well aligned and balanced, right? Their L1 PAs, their T4 PAs, and their C2 tilts are all correct in the setting of a 3D deformity. If that's the case, then you need to plan a surgery that will not mess those up. And as we showed from Peter's stuff, if you take balance in that 3D deformity and you derotate a whole bunch, you run the risk, you're not definitely going to do it, but you run the risk of losing the harmony, in which in the near term, it's not going to be a problem, but it'll probably be a problem in the long term. So they could be well aligned and well balanced. They could be malaligned and well balanced. And in that case, how do we achieve good alignment with harmony? Or they could be kind of at the extreme end of like adult surgery, where they're malaligned and imbalanced, right? C2 tilts off and their alignment's off. And how are we going to plan a surgery to make the shapes and magnitudes right to achieve both harmony and balance? And I don't, again, just like C2 tilt, I don't have it in here. The things we found in the adult world, L1 PA, 50% of PI minus 21. In the kids, 49% of PI minus 19. Same line. It's the same line. We also found in adults that in general, the T4 and L1 pelvic angles are equal. And now one thing, like as you listen to this, I made the mistake, I don't think in yours, but in another talk I did, is that that does not mean that the T4 pelvic angle is equal to 50% of PI minus 21. The T4 pelvic angle is contingent upon your L1 pelvic angle. And with those error bars, right, 4 degrees on each side, you got to know what your L1 pelvic angle is before you can dictate where T4 is supposed to be. But in pediatrics, in AIS, sure enough, T4 minus L1, it's pretty close to 0 in almost all of them. It's a really tight, normally distributed bell curve. So they are finding harmony and balance in a similar way using this, what Newton called it the Kelly shadows. And then we need to figure out how we're going to move something in this XYZ coordinate plane to maintain the harmony. So now look at our case, right? Most of the kyphosis is from T2 to T7, and it lacks kyphosis from T7 to T11. So what do we want to do? We have to reduce the proximal kyphosis, a flatter rod. We have to add lower kyphosis. And how are you going to do that? It's totally off the reservation, but even in these smaller curves, I'm going around the spine and taking the disc out from the back so I can really make sure that I shorten it enough. And I want to change the shape, and I want to change the arcs. I want to move T11 into the kyphotic arc, and I want to move T12 as the end vertebra of the lordotic arc. So you can see here. And again, that helps you think about the plan. And with this, now I get a custom rod made. And I have a rod that is bent to remove that proximal thoracic sagittal plane and add more caudally. And here we go. So this is post-op. And also, and Matt will laugh at this, when Manish Gupta showed up at WashU and he was using posted screws in the lumbar spine, and one day he was complaining that his stuff was dirty and where is it? And I said, you know why your stuff's all dirty? It's because they got to go to the Smithsonian and get all this old stuff out with your posted screws. I have a, like, my personal bias now is that I have a feeling that to some extent we may, as we move towards precise alignment, personalized alignments for spine, that we are going to need to go back to posts, because only with posts can we ensure that where that thing is going is where it's going. Tulip heads have too much play. They're easy, but I kind of think that maybe 20 or 30 years from now, when we're doing, hopefully we're not doing that many fusions, hopefully we have better things, but when we're doing a fusion, we're using posts and a predetermined plan with a predetermined rod and putting everything exactly where it's supposed to be, not to eliminate complications, but to reduce the probability of bad complications and to maximize the probability of good. It's not about making things zero. If you hit L1 T4 PA, it's not going to work 100% of the time. But what we've shown with the ISSG data is that it works in adults, and now we want to see what happens with kids. So here's this plan now, right? And you can see this is posted screws. And now look at my x-ray, the post-op coronal. First of all, that lumbar spine that bent out to straight, but I said, look at the supine film. There's a little lumbar curvature. The lumbar spine looks like that supine film. I left some rotation. I try not to leave a lot of, I like the right-sided screws to be on FOSS at worst. I really don't try to make the right, like the screws look like kissing screws up and down. I think you run some risk of derotating too much unless you've done some sort of anterior discectomy. Look at the lateral. On the lateral now, that lower thoracic spine is kyphotic. The upper thoracic spine is a bit flatter. I don't have the measurements here, but her PI was 76. Her L1 PA is perfect. It's absolutely perfect on the button. And her T4 PA is 4 degrees less than her L1 PA, which is essentially, I think, close to perfect. And now you'll say, well, what's the big deal? Look at her neck. I think her neck looks better. And that's because as you pull that spine back and you can change where T4 is going to be, it changes what the head needs to do to stay over the pelvis, because she also has slightly less pelvic anteversion here. Her pelvic tilt is slightly higher, which is what you would expect for someone with a pelvic incidence of 76. A pelvic incidence of 76 and a pelvic tilt of 19 is sort of low, and probably some bit of pelvic anteversion, which also can tend to be an uncomfortable situation. And that's it. Yeah, comments, questions.
So, again, as somebody who doesn't do AIS cases, you know, somebody might look at this result on the sagittal to the right and say quickly, well, I'm just kind of eyeballing SVA. Does she look a little overcorrected, too far back? What's going on here? When you look at this, when you're looking at this, and obviously SVA is not good, et cetera, for a variety of reasons.
Stinks.
But yeah, I think everyone probably agrees. But there, you know, but it's the first thing you go to and you're looking at, and you're kind of just kind of ballparking. When you look at these, the first thing you're thinking about in your head for overall, you're probably thinking closer along L1 pelvic angle. I mean, is that kind of what the first thing you're kind of drawn to when you're looking at their overall alignment?
First is that where C2 is.
You're looking at C2.
Her C2 is over her hips here.
Yeah.
If C2 is behind the hips, right, and back with, you know, with the C7 SVA that's too low or negative, and C2 is back behind her sacrum, you are up the creek.
Yeah.
Humongous problem where they either PJK or antevert their pelvis, because that's like a low PI patient that gets too much lordosis sometimes will antevert their pelvis to maintain C2 tilt of 0. Bruce Lee calls that the anteverted type 3. There's some of them actually floating out there in the population, but for a patient that's fused, it's a really uncomfortable situation, in part because of the hip joint capsule and what they do. So I look first at C2. How,
Got it.
because now if she stands like this, I don't think it's going to move around very much.
Got it.
And then I measure the L1PA, and that's part of it, like trying to figure out what's going on, because I don't know how the low lumbar spine or how the lumbar spine responds to this. Other studies that we did, so Baron Launer and Arun Hariharan, who's down at Paley in Florida, he did a great study where they looked at when your fusion ends in the upper arc of lordosis. Or so, yeah, your fusion for AIS ends in your upper arc of lordosis. What's really funny, if you like look at those films, like even like, I don't know, have Lumen come to conference and show some, a lot of the times that last disc looks like this. It's really lordotic, almost because you take all that, it's like squeezing the toothpaste out of the tube. You squeeze all the lordosis that's in that thoracic spine and then it sticks in the last segment. What he found was the more lordosis you put in the upper lumbar spine, the more they lose in their lower arc. And the more 4-5-5-1 flatten. And I think that's probably also a terrible situation, because that takes that segment of the spine that in everybody is supposed to be quite lordotic and have the gravity line going dorsal to the disc and the weight going through the joints. And now instead the weight's going through the discs, and the discs are under more compression. And over time, I think that they'll burn out faster than if you had good alignment.
I see.
Anything else? Any questions?
We had a question here that let's see. I think Mike.
Someone said, "Don't take me out, please."
Let's see. Yeah. Let's see. Mike, I don't know if you can see the question. I'm not quite sure if I understand it from. It looks like from Angeli.
Yeah. I think Mike Selby answered it a little bit. I think that good braces, and I'm not sure that a Boston brace is the best. And again, hopefully as we get better, particularly with like using instant surface topography in the clinic and making really customized braces to the flavor of the scoliosis, as opposed to a thing that just tries to 3-point bend you. I think that controlling the rotation may help quite a bit. I haven't made my way through it. Renee Castellane had a PhD candidate under him. He sent me his thesis. It's like 360 pages. It's unreal. It's amazing. 360 pages about the pathogenesis and etiology of AIS. And they talk about how it's a posterolateral, it's a disc-based phenomena. It's not a problem with the bones. It's a disc-based phenomena with a posterolateral rotatory subluxation. And that happens, and then it's off to the races.
All right, so
sorry.
Yeah.
Charles asked about. I like making the plan, and then you can trace the rod. You know, if you can't buy a custom rod, you can at least make your plan and have it put the rod, and then you know what it's supposed to look like. In this case, is really fast.
For the recording, I don't think the comments show up. So the comment here was, do you mind discussing your technique in determining the appropriate rod profile with these goals in mind? So
yeah, sorry. I think you can draw the rod, like draw a shape on the back of the spine so that you have some idea of what it's supposed to look like. This case, actually, very fascinating one because it harms. They brought it up, oh, rod contouring, and who would ever put lordosis into the rod at the thoracolumbar junction? And I said, I might. I mean, I'm never going to say never, never going to say always, never say never. And it was like, I was like some sort of heathen. But if you have a high PI and you're trying to set that upper arc of lumbar lordosis, sure enough, 12-1 is going to be lordotic. And when we bought these custom rods, they came and they got a little, like a little pigtail right at the bottom, right at the TL junction. Because I don't think it's actually supposed to be 0. I think things are supposed to have shapes. And then Mike Selby asked, how does growing changes in PI explain the low PI often seen in Scheuermann's? I haven't the foggiest. I think one thing for Scheuermann's, Scheuermann's seems to have a different etiology, at least, than AIS. I think Scheuermann's has got to be some sort of anterior spinal growth arrest. at the level of the, the growth plate in the end plate, and that's why they get Schmorl's nose and have really ratty looking discs. Or it's an originally disc-based phenomena, and then the discs degenerate and loads the body too much in the anterior column. All right, now I'm like thinking on the fly, and it could be wrong. Episode of hypomania that Goodwin's familiar with. If you have a low PI, and you have some problem that causes your discs to degenerate, you'll probably developing a type 1 Rousseli shape, which is a long sweeping thoracic kyphosis. And now if you're growing, and so we have Heuter, Volkmann, and Wolff's law that can apply, and the discs aren't there to absorb load, the front of the spine may not grow enough. And as the back of the spine continues to grow, then you can end up with Schorman's. You can end up with wedged vertebra, because your normal shape of spine is supposed to be a pretty profound sweeping kyphosis. Alfredo asks, in lanky fives, why do they look more kyphotic above fusions? Not as PJK, but close to. Alfredo, that's a great question. And I think that's something, I think we need to do a better job with these. You know who didn't get ugly PJKs for lanky fives? The anteriors. The anteriors, because they could shorten the front. And it's these all posterior approaches where we swing this thing around, and we, in a lanky five, I really believe we really monkey with the L1 pelvic angle and the shape. And that's where also knowing the lengths of the spine, knowing where it's going to go as you correct it, and once you've corrected it and pushed that apex back under, knowing how much you need to change each segment to ensure that you don't give it a funny looking. So a lot like the extreme lanky five looks kind of like an upside down spine, where you really swing that apex around, but the apex, as we know from Peter's paper, is quite lordotic. And so now you've got a lot of lordosis up high and less lordosis low. And the only thing that can happen is they'll degenerate caudally, and they can start to fill proximally. I think lanky five is a great example. And again, those, like, because it's just like a T-lift in the lanky fives, I'm very aggressive about taking the disc out, so that we can try to replicate what we used to do through the front, through a posterior incision, and shorten the front.
Well, Mike, I feel like this, you're like getting me excited about cases that I don't even do now, thinking like I need to be thinking more about this. And then I'm like, wait, I don't even do these cases. But this is awesome. Thank you for doing this. I think we might need to have some sort of standing invitation for you to periodically like do something like this, because this is actually really fascinating, and it's a lot of fun for me to see you push this forward with things that I understand a little bit, and hearing you kind of talk about where things are going kind of in real time is pretty fascinating. So thanks for sharing that.
Thanks for the invitation. I love talking about it.
All right. Well, thanks again, and I think we'll send out something about it next week and then in the upcoming days here. Thanks, Mike.
Great. Thank you. Good to see everybody.